Good morning, everyone. I'd like to call this public hearing of the House Aging and Older Adult Services Committee to order. It's incredibly busy at the Capitol today and every day as we get closer to budget season. So we are busy schedules, silence their cell phones and electronic devices. Also, to remind people watching at home or in the room that members serve on multiple committees, which require them to juggle their schedules. And so if you see people coming and going, that's the normal course of business here in the Capitol. Today's hearing is on HB 1310, which provides a floor for the Revenue Adjustment Neutrality Factor, which is applied to nursing facility rates. And we have, on our first panel, we have the good fortune of having one of our Department of Human Services Deputy Secretaries, Juliet Marsala, with us, who leads the Office of Long-Term Living. So if we can have the first panel come up, we'll get right to work. Chairman, yes. We're going to have, is Steph going to take attendance for us?
You can just ask members.
Yeah. Well, we'll just have members introduce themselves. I'm State Representative Maureen Madden. I represent the 115th Legislative District in Monroe County.
Steve Menser. I represent a district in Lancaster County.
Shelby Labs, 143rd Legislative District, Bucks County.
Lisa Borowski, 168th in Delaware County.
Bridget Kozarowski, the 114th in Lackawanna County.
Dan Gogan, our 35th District, Allegheny County.
Tara Khan, 194th District, Philadelphia County.
And we have Rep. Marla Brown on virtually attending. Chair Menser, before we start, did you have any remarks?
Thank you, Chair Madden, for scheduling the hearing on House Bill 1310, which seeks to provide a floor for the budget adjustment factor. These issues are complex, and I appreciate the opportunity to gain a clear understanding of the payment process pertaining to the skilled nursing facilities, as well as the impact of HB 1310. I also appreciate the opportunity to hear from the providers regarding the challenges that they are encountering and potential solutions to these challenges, including regulatory reform measures.
Thank you, Chair. I would just like to add, as we all know, Pennsylvania's long-term care system is in crisis. Our frontline caregivers continue to show up understaffed, underpaid, and overstretched, while facilities struggle to keep their doors open. Meanwhile, families face sleepless nights, worried about whether there will be a safe, dignified place for their loved ones to receive the care they need. House Bill 1310 seeks to help by bringing predictability to a system currently held together by uncertainty. It establishes a permanent minimum budget adjustment factor, or BF, of 0.90, a floor that ensures nursing homes won't be blindsided by year-to-year funding shifts. This would allow facilities to plan responsibly, invest in their staff, and meet the real costs of care without scrambling to fill financial gaps at the expense of quality or safety. There have been many questions about the legislation and specifically its price tag. So I'm really hoping that we can have some clarity today after we all testify and we can move forward. And thank you so much, Secretary Marsala, for starting us off.
Good morning, Chair Madden, Chair Menser, and members of the House Aging and Older Adult Services Committee. Thank you for the opportunity to share testimony on this subject of House Bill 1310, introduced by Representative Bizzarro. I have with me our Bureau of Finance Director, Dan Shar. Should we have to get into the weeds of, as you said, complicated
Thank you for being here.
Methodology. So the department appreciates the committee's interest in addressing concerns raised by the nursing facility industry related to funding. And my testimony today will touch on the Medicaid rate setting as it relates to nursing facilities and how the application of the budget adjustment factor, or the BAF, supports the interest of both the department and the General Assembly throughout that rate setting process. I'll explain why setting a floor for the BAF is unnecessary to address concerns related to the Medicaid funding of nursing facilities. Medicaid, known as medical assistance in Pennsylvania, is the main payer for the large and growing population of older adults and individuals with disabilities who need nursing facility services. And nursing facilities serve Medicaid beneficiaries in addition to individuals with Medicare benefits, individuals with Medicare Advantage plans, individuals with private insurance, or the ability to pay privately for their care. Within the Medicaid program, nursing facilities receive a base payment, which are typically paid on a per diem or a per day basis. They receive access to care payments, which are paid on a per claim basis. When a claim goes into the Community Health Choices Insurance Program, they get additional payments attached to their base payment. In addition, we have nursing facility quality incentive payments that are above the base rate payments. And there are other supplemental payments that are typically paid out in a lump sum. So in accordance with the federal Medicaid reimbursement requirements and to ensure that the base payments align with residents' needs and nursing facility resources, Pennsylvania uses a case mix reimbursement methodology to calculate the nursing facility per diem rates. Those are the base rates, not any of the other payments. This methodology calculates rates for facilities based on the cost to deliver care and the acuity of the residents. So it factors in how complex a resident's needs may be as part of that methodology. And the resulting calculations ensures that nursing facilities who care for Medicaid beneficiaries with the higher needs receive a higher Medicaid reimbursement rate. And those rates are adjusted quarterly based on the nursing facility's changing population. So the BAF doesn't change that, the case mix methodology does. And so if the volume of Medicaid residents and their level of care needs go up, then that nursing facility's case rates will go up. So since facilities report their case mix to the state, they know roughly what to expect with regard to how their next quarter may be adjusted based on their population that they serve. And the variability resides with how one facility's case mix compares to that of other facilities across the Commonwealth. So everyone is kind of compared together. And it's this case mix methodology that ensures the Medicaid funding is reimbursing facilities serving Medicaid beneficiaries with the greatest needs. The BAF ensures that the department operates within the funding appropriated by Pennsylvania's General Assembly and what is appropriated in the annual state budget. And the BAF was implemented in 2005 and codified in statute in 2007 by Act 16 of 2007 by the General Assembly to align the Medicaid nursing facility rates with the actual nursing facility appropriation set by the legislature to ensure the state's Medicaid reimbursement system remains financially sustainable. The history of the BAF, by way of example, explains what happened before the General Assembly codified the BAF into law and why it was necessary. So prior to adopting the BAF, the department utilized a cost-based payment system. Essentially, nursing facilities provided care, and whatever it cost them, they were reimbursed retrospectively. This resulted in many years of growth in nursing facility expenditures and DHS supplemental budget requests to the legislature for more funding. The costs were more than the state budget could handle, and the General Assembly sought to implement cost controls and restore some semblance of predictability in state budgeting for the provider rates. And as a result, the methodology for reimbursement to nursing facilities changed in order to contain those costs to the actual budget appropriated and made each fiscal year for those services. If the calculated rates exceed the appropriation from the General Assembly, the BAF allows the department to limit the payment rate to the amount permitted by the General Appropriations Act for the given year. The BAF is applied directly to the nursing facility's per diem rate, which is the base rate, paid by the department through the fee-for-service reimbursement by the department account through either the fee-for-service or through the managed care organizations. The fee-for-service reimbursements account for less than 10% of Medicaid payments to the nursing facilities. The BAF also indirectly impacts the nursing facility rates through the community health choices. And the community health choices oversees about 90% of the Medicaid payments to nursing facilities. The community health choices managed care organizations are required by the department to pay nursing facilities according to a minimum fee schedule methodology, which is based in part on the facility's per diem rates, those base rates. And so since the implementation of the BAF, nursing facility rates have actually increased on annual an average of $3.65 per day, which is in aggregate about 43.93% overall from fiscal year 2004 through fiscal year 2024-25. If the BAF had not been used, rates would have increased on average annually by $6.28 per day, and we would have seen an overall increase of 75.64%, which exceeds the Consumer Price Index for the same time period. As introduced, House Bill 1310 would set a floor for the BAF at 0.90 or greater, and this means that the General Assembly would be obligated to appropriate enough funding year over year to cover 90% of the department's calculated Medicaid per diem rates to nursing facilities. While this clearly benefits nursing facilities who receive Medicaid payments, it means that the General Assembly will no longer control the nursing facility budget. There would be no limitations on how much Medicaid per diem rates for nursing facilities could increase year over year. Currently, based on the long-term living light item appropriation and the latest quarterly rate adjustments, the BAF is at 83.7%. The BAF adjusts in relationship to the nursing facility per diem rate calculations within the amount of funding appropriated. If the BAF were to increase to 90% for fiscal year 2025-2026, the General Assembly would need to appropriate an additional $352 million in state funds. And that would need to be appropriated to support the increased costs in both the long-term living and community health choices appropriations, because it would have to account for both the 10% in the fee-for-service plus be accounted for in the capitation rates of the Community Health Choices program. So moving forward, nursing facilities will continue to report rising costs, which would be factored into the Medicaid rate setting process and require significant appropriation increases year over year to meet a BAF floor of 90.90. There's little incentive for nursing facilities to control spending. And as a BAF floor means 90% is the minimum adjustment to rates, regardless of what those costs are, it sort of restricts the General Assembly from being able to put in any cost containment measures. Each budget cycle, the General Assembly has the opportunity today to increase the BAF multiplier by increasing the nursing facility rates, as you do every year. So for example, in 22-23, when the General Assembly increased nursing facility rates by 17.5%, the BAF went from 77.9% to 92.3%. In fiscal year 2023-24, when the General Assembly increased nursing facility rates by 1.88%, the BAF increased from 88.9% to 90.2%. And in fiscal year 2024-2025, when the General Assembly increased nursing facility rates by 7.04%, that increased the BAF from 78.2% to 83.8%. So increasing appropriations instead of setting an arbitrary statutory floor for the BAF allows the General Assembly to increase nursing facility per diems while also maintaining the flexibility to consider other budget priorities at the time that the budget is enacted. It also minimizes the risk of the department needing to submit supplemental funding requests to support nursing facilities at the end of the state fiscal year. Lastly, since implementing the BAF in 2005, the department has seen no evidence that the care in nursing facilities has been adversely impacted by it. In addition, although the BAF has served to moderate the overall aggregate increases in per diem rates, the adjusted payment rates, together with the other supplemental payments to nursing facilities, have been and will continue to be sufficient to ensure that Medicaid recipients have access to medically needed nursing facility services, which meets the department's needs. And that includes currently the 41,000 individuals that are being served through our Medicaid programs. We currently have 79,000 licensed Medicaid beds, and only approximately 41,000 of them are filled by Medicaid recipients, which to us shows us that we don't have long waiting lists for nursing facilities, and 77.4% of the individuals we serve are served in the communities where they're choosing to be served. So thank you very much for allowing me the opportunity to provide some testimony and comments today, and happy to answer any questions.
Thank you so much for being here. We'd like to acknowledge that Rep. Eric Nelson has joined us, Representative Kristen Marcel, and Representative Dorisha Parker, and Representative Bridget Kozarowski. Am I missing anyone? Okay. So thank you, Secretary, Deputy Secretary. I have an obvious question, I think. We've seen in excess of 30 nursing homes close in the last year and a half. We're being told by folks that the reason there are so many empty beds is because there aren't people to work there to be able to care for the folks when they get in, and that's why they have empty beds. We really are at a nursing home crisis. If we don't adjust the BAF so that there's predictable funding mechanism moving forward, how do we solve this problem? If it's constantly changing, how is there any predictability? How can nursing homes budget and stay viable and keep their doors open and fully staffed and have all their beds filled?
Certainly. So the variability in rates is not a result of the BAF directly. It's the whole acuity case mix methodology, which changes on a quarterly basis based on the population the nursing facility serves. So even if there was a floor of the BAF, the rates would still change every quarter based on the population the nursing facility serves. To your point with regards to the 30 nursing facilities that have closed, certainly we do recognize that there's a workforce shortage. I don't know what the population needs are outside of the Medicaid program that I oversee. So what I can say is within the Medicaid program, we do not have long waiting lists for nursing facilities. So part of that impact could be that those referrals are just not there, and that there's a shift in the nursing facility industry based on decades of policies that have been set in place to help support people to receive services where they want to receive them, which has shifted from the last 20 years from 25% of folks being served in the communities to over 77% of individuals being served in the community. And that's a fundamental population shift and a shift of where services are predominantly being provided. Nursing facilities are a critical part of our long-term services and support system, but we've seen over the years the sort of, in the Medicaid program, people are choosing the community first.
Thank you very much. Also, I would just like to mention that when we will be introducing an amendment to 1310 that will pause the rate rebasing for the next 2 years, and that would result in an overall increase of $139 million and not the $352 million So I just wanted to put that out there. And I appreciate your response. I just want to say from my standpoint, and I think I've mentioned this, my husband is a musician, and his day job is nursing homes and senior centers. And I've noticed the shift. And before I got this job, my job was booking him and going into all of these facilities and seeing these facilities firsthand. And I can tell you from the standpoint of a musician going into a nursing home and playing and entertaining folks and keeping them upbeat and keeping them lively, right, and giving them a quality of life. We have seen so many facilities have had to stop these quality of life care, right? Because there isn't enough money for the basic services. So we have to do more. We have to figure out a solution to do more for our seniors, because as it stands right now, we are hearing from our facilities that there isn't enough staff. They can't retain staff. They can't fill their beds because they don't have enough staff, and they don't have the money to do what they need to do. We heard at a previous hearing a nursing home owner who said, we need $250,000 for a generator right now, and we're trying to piece it together so that, if it breaks, we can keep it hobbling along, because there's no chance that we have $250,000 for this. I mean, from my standpoint, what does nursing home do when their generator goes down, right, if there's a storm? I mean, these, beyond music and beyond therapy and beyond arts and entertainment, there are very real basic needs of these facilities that are not being met. And from my standpoint, adjusting the BAF and making it predictable and making it something that people can count on seems like a really good start. And that's kind of rhetorical. You don't have to really answer that. I'm just speaking out loud. And we have questions from Chair Menser.
Thank you, Chair Madden. I have a question on the additional payments that are made. Could you give me an example of a nursing facility quality incentive payment? Like, would it be like $3 a day per patient, or is it a lump sum? How's it determined?
Yeah, so the department has a nursing facility quality incentive program that is paid out as a lump sum at the end of the year for the nursing facilities who qualify. And they qualify by taking a training that we put out many times a year, in addition to meeting quality measures, which are oftentimes tied to sort of health measures within the populations that they serve. And so what that incentive program does is it rewards nursing facilities that are showing us the quality of care that Pennsylvanians deserve by participating in our trainings, by bringing their clinicians in for our trainings, and by meeting those measures and agreeing to participate. And so I don't know the full number, but I think this last year, was it around 12 million? 15 million in additional funding was made available to the nursing facilities through that nursing facility quality incentive
I wonder
program.
how many nursing facilities actually received a payment like that? Do you think it would be over 50%?
It was over 50%.
So 50% of the nursing homes are actually getting more than the base.
Correct.
The other supplemental payment, which were typically paid in a lump sum, what would be some of the other supplemental payments?
So an example of a supplemental payment would be a payment made to perhaps a nursing facility in our Pier 13 group that is providing care and support for a larger population than others who utilize ventilators or need increased trach care. And so those nursing facilities at times are provided with supplemental payments.
Yeah, thank you very much.
Representative Borowski.
Thank you, Chair Madden. And thank you very much for your testimony. I appreciate it. And certainly the explanation of the BAF is very helpful, so I appreciate that. My question is going to be, so I have a county nursing home that has 2 floors that they cannot open because of staffing issues. And I know that we're not really talking necessarily about that, and that's related to the CNAs and the CNA ratio. But so given that, and given that these nursing homes are struggling, I think, to find staff, I guess my question to you is, when you make the statement of no evidence that the care and nursing facilities has been adversely impacted. My question is, how do you measure that? Like, what does that look like to you guys when you say has not been negatively impacted? Like, to me, it would seem that some of the reimbursements, some of the staffing mandates that have been set are adversely impacting and not providing opportunity for more people. So I will say that I know my county nursing home has a waiting list. I know they are mainly Medicaid recipients. So, and I'm just using a very small example. So I understand that there's a bit much larger Commonwealth. But my question, so I guess my real question is, how do you measure like the idea, the thought that things have not been adversely impacted?
So from the Medicaid program, we're looking at our quality of care and the monitoring we do within our programs for the services provided to Medicaid members. We're looking at their access to care, and if the Medicaid program has a waiting list, it could very well be that your nursing facility has a waiting list, but that may not mean that there aren't other opportunities within the county at other facilities, or it could be that the individuals on that waiting list are not within my Medicaid program. The Department of Health sets the staffing requirements, so I can't really speak to how they're monitoring that impact. One would think that increase in staffing and increase in care increases quality kind of across the board. So for us in the Medicaid program, it's looking at our CHC MCOs are required to monitor the health of all of their residents. Their service coordinators are going in and visiting with their residents on a monthly basis and visiting with the family members and making sure their needs are met. We are following up if there's any complaints that we have to follow up with our members. We haven't seen an uptick in that compared to other years. So those are just some of the ways in which we in the Medicaid program are kind of monitoring the quality for our Medicaid members.
Thank you.
Rep. Nelson and then Rep. Khan.
Thank you, Madam Chair. Appreciate your testimony. And this is definitely a complicated issue. You know, I was disappointed that your office wasn't willing to participate in the roundtable we had for the Appropriations Subcommittee last week because, you know, the bath was an important component about it. And it almost seems like we're looking at a senior crisis, as the chair had mentioned, with facilities struggling. You know, just the reflection of 30 facilities closing in these last few years and our wage gap issue that I would say is contributing to unusable licensed beds. When you say that if we had the opportunity in the budget that the legislature would have that control, but this budget is over $900 million increase going to CHC that the legislature has absolutely no control over. So if we were doing the bath through these years, do you think that would have helped prevent some of these facility closures?
So the $900 million increase that you said the General Assembly did not have control over, the majority of that is directly related to the nursing facility increases that were appropriated in years past that are then annualized through our programs in the cost to carry.
Correct. Cost to carry means
right,
we do not have control over those dollars.
Well,
and as you're mentioning the shift, which it is, I mean, there's great benefit in the home health care, but when we look at home health care, I think my understanding is over the last 10 years there's been 3 increases. I mean, it's maybe since 2014, less than $2 in that shift. So, like, we're looking at this barren land of senior care across all continuums. So it is, back to the question, if we would have had a bath, do you feel that would have helped prevent facilities from closing?
Well, you did have a bath through those years. the BAF is in place today. So is the
this
question
level,
is
at the 90.9.
okay? I don't know. There are nursing facilities that are managed really well. There are nursing facilities that struggle in their management. And I think there's a lot of factors that go into whether or not a nursing facility is successful or not, how they handle their case mix from their private pay, their Medicare, and their Medicaid residents, whether or not a nursing facility has a lot of temporary staffing. I just visited a nursing facility in Bucks County that had 0% of agency staffing. And agency staffing is very costly. And they have 0% because of the culture they create, how they manage their teams. They have an executive team that has been there for over a decade for the most part, and they've figured it out, and they have very high quality care. I don't see them at danger of closing. You have others that have a higher rate of agency staffing that are paying a higher administrative fee, redirected outside of their facility. So I couldn't predict whether or not having a BAF at 90 would have saved those nursing facilities or not.
Sure. I know I'm out of time. Thank you, Madam Chair. But it really seems, as we're trying to come up solutions across the continuum, that the BAF potentially may be a positive tool along with a host of other solutions, because it appears that the CHC program is failing. It's doubled in cost. It is completely non-transparent, and it seems to be going in the opposite direction of increasing quality of life for seniors. Thank you, Madam Chair.
Thank you. And we've been joined by Representative Serrato and Representative Khan. You're next for a question.
Thanks, Chair. Actually, Representative Nelson stole my question, so good question, Rep. Nelson. I have another one. So the governor has proposed, and this legislative body is actually ready to vote to increase funding for Medicaid by about $2.5 billion. It's to help the solvency with the program, make sure providers are taken care of, make sure folks in nursing homes are able to be taken care of. But unfortunately, we see what's coming out of Washington is quite different. In fact, if the current bill that is being proposed gets passed in Washington, we're going to see about $2 billion get cut from Medicaid here in Pennsylvania. 300,000 people lose their health insurance here in Pennsylvania alone. And I was wondering if you could just talk about, if these cuts to Medicaid go into effect federally, what may we expect here for nursing homes here in Pennsylvania, which, as has been noted, have been closing at a rate of about 5 per year over the last few years?
So I wish I had a magic ball to figure out what's going to happen at the federal level. I think we all do. To the question, and I'm kind of not prepared to talk about sort of Medicaid impacts at a broader level, but to nursing facilities specifically, nursing facilities are an entitlement. So they're in the state plan as an entitlement. They're in the Social Securities Act as an entitlement. So for nursing facilities directly, there is an obligation to pay those costs first. Now, again, as I've stated before, setting the BAF at a minimum level does not, keeping it as it is today, does not impact the General Assembly's ability to appropriate rates based on the budget that you want to set forward. So if you do nothing today, you can still change your appropriations higher or lower based on your needs that you hear from your constituents, based on what you're seeing across the Commonwealth and all the different priorities. Setting a minimum floor for the BAF takes away that ability for the General Assembly to address those appropriations and adjust them based on the priorities and the needs of your constituents.
Thank you so much for being here. Thank you for your testimony. Thank you. And enjoy your day. We're going to call up panel 2, consisting of Matt Yarnell from President SEIU Healthcare, Tina Siegel, LPN, Clarion Health and Rehab Center. We're having everybody come up, right? Zach Schamberg, President, CEO, PHCA, Chuck Quinnen, Senior Vice. I'm not waiting for you to come up when I call your name. Everybody, just come up. Thank you. We're so happy to have you all here today offering testimony. Again, as I said, Matt Yarnell, President, SEIU, Tina Siegel, LPN, Clarion Healthcare and Rehab Center, Zach Schamberg, President and CEO of PHC, Pennsylvania Home Care Association, Chuck Quinnen, Senior Vice President and Chief Government Affairs Officer of Leading Age PA, Jason Schott, Phoebe Ministries, and Anna for moral support. That's awesome. All right, let's start with you, Matt.
Great. Well, good morning. And as you said, my name is Matt Yarnell. I'm president of SEIU Healthcare Pennsylvania and a former nursing home worker myself. I first want to thank the chair, Madden and Metzer, for and the members of the committee for inviting me to speak about nursing homes today. Our union has entered into a partnership with the Pennsylvania Healthcare Association because we know, just as you all do, that the state of Pennsylvania nursing homes is in need of real change, and in particular, high Medicaid homes. Short staffing is the main reason why people don't stay in this profession long anymore, and many caregivers left during the pandemic and never came back. On top of that, the resident to aide staffing ratio being a challenge, the pay rate for CNAs is not competitive enough to convince people to stay in this work. That is why it's so important to make these good union jobs. They have to have competitive pay with good benefits like health insurance, retirement, and childcare. There's no need to sugarcoat where we are. Investing in quality care and a strong long-term care workforce will take getting more resources to the bedside. That is also why we are supporting House Bill 1310, which would raise the BAF floor to 0.9, as we just spoke about earlier. The BAF floor being set at 0.9 would stabilize funding for nursing homes. As it exists today, the BAF prevents changes in real reimbursement rates to meet changes in the actual cost of care for nursing home residents. Year over year, this puts strain on our caregivers, squeezes staffing, and makes it challenging for high-road providers to invest in their workforce. It is also why you as a legislature see us all the time talking about more resources to the bedside along with PHCA and other advocates. Stabilizing funding would make it easier for operators to adequately staff nursing homes, improve quality care for residents. Predictable, stable funding works in conjunction around accountability, like the care ratio that you all worked on, which requires 70% of Medicaid funds to be spent on bedside care, and also regulations like the staffing ratios to ensure funding gets to the bedside and supports continued progress towards a system of high-quality care across the Commonwealth. It's vital that we, the workforce, industry, and policymakers deepen our partnership to make this possible. Thanks again to the committee for having me speak today. I didn't want to take up too much time because I want you to actually hear from Tina Siegel, who's a 40-year nurse who's done this her whole life. So I'll stop there and maybe see if there's any questions, but I think Tina is who folks should hear from this morning. Thanks.
I think we'll just let everyone testify and then ask questions. Go ahead, Tina.
Okay. Good morning, Chair Madden and Metzer, and members of the Aging Committee. Like Matt said, my name is Tina Siegel. I work at Clarion Healthcare and Rehab Center as a licensed practical nurse. I've worked at that facility for the past 40 years, so I have seen changes in the care that residents receive. When I started working at Clarion, it was because I wanted to help people and to make a difference in their lives. And for much of my career, I felt like I was doing that, and it was making the difference in my residents' lives. When I started working there, we had a lot more time to actually spend with the residents. If a resident was going out for the day and they wanted to be dressed up a little, you know, they wanted to look good for their families, we had time to dress them. We had time to do their hair. The beauty shop's there once, maybe twice a week. So we would have time to do their hair and stuff to make them feel good about themselves. And we actually had time to talk to them. You know, they would tell us the stories about their family or, you know, things that they have done in the past, which, you know, they have a lot of information there that's very interesting that comes from the elderly. But right now, things have changed. And now the nursing home feels different. As an LPN, I have a lot of responsibility. I pass medications, responsible for IV meds also. I care for open wounds and sores. Some of them require a lot of care, take a lot of time to take care of. And I help residents to the bathroom when they need it, or I help feed residents. I also oversee the nurses' aides. And they bathe the residents, take them to the bathroom, but sometimes they need some more help. So that's why we're a team, as the LPNs and CNAs, there to care for the residents. And I can tell you that the quality of care has gone down. We are responsible for so many more residents now, and we don't have the time we used to really connect with our residents and spend time with them. There's a lot more acuity in care. They require more care. We're getting residents right out of the ICU. You know, it's not grandma and grandpa coming into the nursing homes anymore. They come directly from the ICU, so they're requiring more time for you. And working in a nursing home, the residents become our family. Some of them don't have families, so you are their family. And that's important to us as caregivers. And we have spent, myself included, spent money on different things for the residents because they don't have family members to bring it in. You know, some facilities, you know, just want the residents to drink water all day. You know, they don't offer them juice. So, or they might have a specific juice, you know, they get a Kool-Aid mixture, or they might want a specific soda that's not available. So we as staff members bring that into our residents. I had one lady that I was particularly close to, and she liked to draw or make her own cards. She would take a white cardstock and she had colored pencils. If something funny happened that day, or you did something funny, or it was your birthday, or something else, she would take those colored pencils and make cards specific to that staff member that day and what had happened. So, you know, when I had time and had some extra money, I would buy those cards and those pencils for her. And she was happy, you know, that was her. She couldn't get out of bed very often, so that was her joy in life, was to make those cards for our staff members, which she has passed now, but I still have those cards, you know, because they meant a lot to me. Because we really do care about our residents, and they care about us. That's why I feel so strongly that we need to improve quality care in nursing homes. Sometimes people ask me, why did you stay there all this time? And I tell them, because I have stayed there, because I know things can be better, and I want to be part of that solution. You know, I could just retire and say, you know, my work's done, but I feel these residents deserve better. And that's why I'm working so hard to make things better for them. And we know as the population is getting older, myself included, we need to make sure that nursing home jobs are well-paid, union jobs with safe ratios in place, and that our aging neighbors have the care that they deserve. And I know as a union member, I don't feel like I'm going to be retaliated against. If I see something that I feel is going on incorrectly in my facility, you know, I can report this without a fear of risking and losing my job. And because of the union, we have labor management meetings. We see where we feel something could be going a little differently to make things better in the facility. So we meet with management and we say, you know, this is our solution. And a lot of times they'll work with us to make that difference. So, you know, as a union, they have given me a voice to make things better for my residents in the nursing homes. And I just thank you for letting me talk about my job and my story today. It means a lot to me. Thank you.
See, now we do want to applaud. Thank you, Tina. Thank you for your dedication for over 4 decades. Thank you for sharing the amount of love and care that you have for the residents. My mom spent 10 years with dementia in a county facility, and I understand that on a very meaningful level, how important they become. And we're working really hard to give you all the resources that you need. Zach?
I asked you not to let me follow Tina, by the way, so thanks a lot. Chairwoman Madden, Chairman Menser, members of the House Aging and Older Adult Services Committee, thank you for the opportunity to testify today. And thank you, Chairwoman Madden, for teaming with Policy Committee Chair Ryan Bizzarro on this important legislation that I think could quite literally save the long-term care continuum in Pennsylvania. My name is Zach Schamberg, and I'm the president and CEO of the Pennsylvania Healthcare Association, or PHCA. We represent nursing homes across the Commonwealth, as well as personal care homes and assisted living communities. As some of you know, this is actually the second opportunity we've been granted to talk about the Budget Adjustment Factor, or BAF, and its impact on Medicaid reimbursement for nursing homes in our state. The first was Chairman Bizzarro's Policy Committee hearing in mid-March, nearly 3 months ago. So the question that I had is, what's changed since then? What can I tell you today that I couldn't in mid-March? The truth is, I believe the BAF is still the most destructive budgeting tool the state of Pennsylvania has in its arsenal. It quite literally creates a reimbursement ceiling and withholds funding from our nursing home providers, from their caregivers, and from the vulnerable senior citizens they serve in the name of keeping a line item within budget. The BAF is still the reason that nursing home providers cannot make caregiving wages family-sustaining wages, and it is still the reason that a workforce crisis exists in this Commonwealth. It is the reason that Pennsylvania's reimbursement rate pales in comparison to every single neighboring state, including Ohio, Maryland, West Virginia, New York, and New Jersey. And it is still the primary driver, as the chairwoman mentioned, of 30 nursing home closures since 2019, and an access to care crisis that has forced seniors and their families to, in some cases, travel out of state just to find the care that they need. But I think what's new, and what really struck me today, is that some will actually argue in support of the BAF, a mechanism that was supposed to be a one-year fix in 2005 by the Department of Public Welfare to control nursing home costs. And I want to be very clear today. To support the budget adjustment factor is to support those 30 nursing home closures that have taken place since 2019. To support the BAF is to support the market volatility that we've experienced in long-term care, in which nearly every day a new nursing home is either being sold or reorganized or changing ownership or being forced to file for bankruptcy because the reimbursement cannot come close to sustaining operations. To support the BAF is to support the nearly $68 per resident per day shortfall between the state calculated rate that providers should be paid and what they are actually being reimbursed. $68 per resident per day. 3 months ago, Chairman Bizzarro's Policy Committee hearing focused on the sustainability of long-term care. And that's what we're talking about today, sustainability. Does that and the budget adjustment factor sound sustainable to you, given our aging population? And keep in mind, the vast majority of payment or reimbursement for nursing home care is Medicaid. The BAF is more impactful and more detrimental to facilities serving a high Medicaid population. We said it then, and I'll say it again today, the system is set up for providers to fail, and in turn, we fail those who are entrusted to us for their care. We are one of only 5 states in the country to utilize a BAF for nursing home reimbursement, and nursing homes are the only entity in Pennsylvania that are subject to a budget adjustment factor. So at the end of the day, if a state budget is a statement of our priorities and our values, what does it say when we balance our budget on the backs of our seniors and their caregivers? Why are they the only group in Pennsylvania that are treated this way? And to put it differently, if a budget adjustment factor existed for our school systems and our education funding, would we think that's fair? If it existed for public transit or our roads and our bridges, would that be fair? So why is it fair for our grandparents, our relatives, our neighbors, our most vulnerable residents to have this placed on them? Given our aging population, we need to start treating our seniors in nursing homes the same way we treat our children in schools or our public transit. We need to make them a priority in our state budget. And to do that, it's fairly simple. We make House Bill 1310 a real priority this year. We make this a fairer, more equitable system. And keep in mind, with a 0.90 BAF floor, we're not even advocating for every single dollar to be sent to providers, workers, and residents. Just a floor to ensure enough funding could be reinvested back into the care of our residents or into a caregiver's hourly wage. Last year, for the members of this committee alone, the BAF cut $127 million from the nursing home workers, residents, and providers in your districts. If this bill had become law and we had had a 0.90 BAF floor, $59 million would have actually been allocated to nursing homes in your district. That would save long-term care. Now, we understand the fiscal realities that you are facing this year, but our aging population and the providers and workers who care for them deserve better. They deserve a system that works, and that's what we're fighting for. Thank you again for the opportunity.
Thank you. Chuck?
Good morning, Chairs Madden and Menser, and members of the House Aging and Older Adult Services Committee. I'm Chuck Quinnen, Senior Vice President, Chief Government Affairs Officer for Leading Age PA, an association representing over 400 mission-driven providers of aging services, including the full spectrum of care and support from personal care homes, assisted living residences, nursing homes, living independence for the elderly programs, affordable housing, and more. I'm grateful for the opportunity to discuss with you today the problematic BAF and the related financial challenges our member providers are facing. And thank you, Chair Madden, and other members of the House Aging Committee for your leadership on this critical issue and for working with Representative Bizzarro on introducing House Bill 1310. As you heard, that would help protect nursing home care for those who need it by implementing a 0.90 floor to the BAF. This would not only provide greater predictability for providers who are confronted with worsening rate volatility, but also greater sustainability for the system on which our growing population of older adults depend on. Leading Age PA is dedicated to our mission-oriented members delivering high-quality, affordable, and ethical aging services. With me today are two key individuals. Jason Schott, COO from Phoebe Ministries, who will be sharing Phoebe's story and experience in a little bit, and Anna Warheit, Leading Age PA Regulatory Affairs Director, who hears from our members on a regular basis about the challenges they are facing as a result of the BAF and related factors. What you'll hear today from Jason is not uncommon. The BAF is imposing additional strain on a reimbursement system that is already drowning our nursing home providers. Phoebe is just one example of the many organizations providing care to our state's most vulnerable residents who must bear the devastating effects of a broken funding system. To share the voice of another Leading Age PA member, a 5-star nursing home community in Lancaster County, they recently shared that the actual current cost of per resident per day Medicaid, or not Medicaid, but the actual per resident per cost that they encounter is $584, yet the reimbursement rate calculated by the state for this provider is only $316. Even if the state reimbursed at 100% of that fully calculated rate, it would only cover 54% of the provider's costs invested in each resident's care and operational expenses. But we don't reimburse at 100%. The BAF further reduces reimbursement to approximately 3/4 of the calculated rate. Therefore, instead of receiving $316, this provider receives $265. an additional loss of $51 per resident per day, for a total loss of $319 per day per Medicaid eligible resident. Over the course of 2024, this provider lost nearly $500,000 strictly as a result of the bath. We are piling on losses in the system that already does not factor in total costs. When all is said and done, caring and quality-driven providers are being paid only a fraction of the cost of it actually takes to provide this level of care. We estimate that most of our members are reimbursed only 45 to 60% of their actual expenses. Now, we're not here today to ask the Commonwealth to reimburse providers at 100% of actual costs, but simply to provide a reasonable floor to the bath so that the burden of ensuring access to quality nursing home care doesn't rest solely on the shoulders of providers. As one member shared, quote, "This lack of funding from the state transfers the cost of care for our Medicaid residents solely to the facility, and our only option is to raise rates on our private pay residents to cover the gap. This becomes a vicious cycle, as you can imagine, with those residents spending their resources at an accelerated rate and ending up on Medicaid more quickly. Facilities cannot be expected to be the stopgap on this issue. This will lead to more facility closures and create even more dire access to care issues," end of quote. Across the state, providers are reducing their overall census and/or Medicaid occupancy as a result of this reimbursement shortfall, which is further exacerbated by the ongoing workforce crisis and prescriptive per-shift staffing ratios that make it impossible to operate at full capacity. Providers are running out of alternative revenue streams to offset these losses and continue to face additional increased costs stemming in large part, again, to the workforce crisis, staffing mandates, and as it was mentioned, temporary staffing agencies taking advantage of the increased demand for workers. So what does this mean for Pennsylvania? If we can't find a way to reduce the gap between cost and reimbursement, more and more providers will be forced out of Medicaid participation. As you heard, approximately 70% of older Pennsylvanians who either cannot remain safely at home or prefer the social and clinical benefits of 24/7 nursing home care rely on Medicaid. These are our former teachers, pastors, police officers, and community leaders, individuals who have dedicated their lives to bettering their communities, only to outlive their resources through no fault of their own. When we fail to invest in the organizations whose mission it is to care for them, we fail to invest in the heart of Pennsylvania, and those who came before us and now depend on us to ensure they have the care they need and deserve. If providers like Phoebe have to further reduce their census or stop accepting residents on Medicaid altogether, there will be nowhere else for these individuals to go. We must do better. We appreciate the opportunity to share the challenges faced by our members. Passing House Bill 1310 and implementing a .90 floor to the bath will go a long way towards fixing this broken funding system. Thank you again for bringing up this critical issue. We look forward to continuing to work together towards meaningful change. And I would just add, I know it was discussed before, in listening to the department's testimony, and there's it seemed to imply that there wasn't a funding crisis. And I know it was mentioned about the number of nursing homes closing over the last 5 years, over 30, right? In addition to that, there's been thousands of nursing home beds taken offline because of the funding and workforce crisis. And this has created an access to care crisis. And it's also important to note the impact it's had upstream in the healthcare ecosystem when hospitals are unable to discharge patients timely who need nursing home placement. It creates backups in emergency departments. It reduces bed capacity in the hospitals themselves. We must do better as a state. Burying our heads in the sand will not make these problems go away. We have a responsibility to the older adults in our state. And lastly, the department's testimony implied if a bath floor is implemented, providers will suddenly have the luxury of unchecked spending and straightforward reimbursement for whatever they feel like spending money on. But we still have the state-directed payment rate that's based on case mix and allowable cost that still limits what the rate could even be. We're just asking for a bigger piece of the rate that the department itself says providers have earned by their own calculation. Thank you.
Jason?
Good afternoon, Chairs Madden, Menser, and members of the committee. My name is Jason Schott, and I serve as the Chief Operating Officer for Phoebe Ministries. We operate 4 continuing care retirement communities and 8 affordable housing, senior housing communities across Pennsylvania. Thank you for the opportunity to speak with you today in support of House Bill 1310, and thank you for Chair Madden for your leadership on this critical issue. Leading Age PA recently commissioned a case study by independent consultants RKL LLP using Phoebe Allentown as a focus to compare costs and reimbursement. At Allentown, we serve over 385 residents across independent living, personal care, and skilled nursing. Although licensed for 395 nursing beds, we currently are only utilizing just 250 due to staffing shortages that began in 2016 and worsening during the COVID pandemic. The state's prescriptive mandates have only further strained operations. In 2024, our Medicaid occupancy averaged 72.3%. That's about 180 residents on Medicaid in Lehigh County. The budget adjustment factor continues to reduce Medicaid reimbursements below already inadequate levels, deepening an unsustainable funding gap. In 2018, Phoebe was reimbursed 77.6% of Medicaid cost with a $4.6 million shortfall. By 2024, the reimbursement dropped to 59.5%, and the annual shortfall ballooned to $12.2 million, even though Medicaid days remain relatively constant. At Phoebe Allentown, we provide more than 600,000 Medicaid days per year. At that scale, even minor rate changes have massive impacts. For example, every 0.01 decrease in the BAF increases our daily loss by 3.37 per resident day. When the BAF dropped 0.11 between April and July 2023, that translated to $13,530 more in losses per Medicaid resident annually. To cope with these deep and ongoing losses, especially those tied to Medicaid, we've had to make painful decisions. We recently sold our Wingcote facility in Montgomery County, where over 60% of SNF beds were Medicaid funded. Continuing operations under financial strain was no longer feasible. We're now at a crisis point not only at Phoebe Allentown, but also at our Richland and Berks campuses. All 3 communities are now operating with Medicaid occupancy over 50%, a stark contrast to their historical average years ago of just 20%. These shifts leave us severely underfunded while our costs continue to rise. To remain open at all, we've also had to implement dramatic census reductions, scaling down from 395 licensed beds at Allentown to just over 250 currently in use. This directly limits the number of vulnerable older adults we can serve, and the gap only grows wider as our operating losses continue year over year. Our options to close the funding gaps are exhausted. We cannot cut quality of care. Medicare stays are limited to short-term rehab or declining. Each Medicaid admission results in $100 to $300 lost per day compared to Medicare or private pay. We've reached the limit of what we can charge private pay residents, and any increase only accelerates their spend down to Medicaid. We're stuck with rapidly rising costs and no tools to increase revenue. Since 2017, our daily cost per resident day has increased from $370 to $439 a day, a 19% increase. Our largest cost driver is staffing. We now rely heavily on temporary staffing agencies due to shortages and new staffing mandates. In 2023, we logged over 37,000 hours, equivalent to 4,729 8-hour shifts. Agency rates are significantly higher. RNs are $10 more an hour, LPNs are $13 more an hour, and CNAs are $8 more an hour. This reliance costs us over $400,000 annually beyond what we spend on in-house staff, as a negative impact on morale, resident care, and culture. Despite the increased costs, our hours per patient day have declined. From 2016 to 2020, we've maintained a per patient day of 3.6. In 2023 to 2024, we're barely hitting the minimum required 3.2, even with heavily agency usage. Even with these challenges, Phoebe remains committed to quality of care. The 2023 state budget requires 70% of costs to be spent on resident care. We exceed that with 77 to 80% of our costs directly supporting resident care and related services. But unless Medicaid reimbursement improves, the number of services we can care for will continue to fall. Since 1903, Phoebe Allentown has served older Pennsylvanians with compassion and clinical excellence. We are proud to provide charitable care to those who have outlived their financial resources, but we cannot sustain this level of service without the support from the state. The elderly and disadvantaged, so often forgotten, are the heart of our mission. We are counting on your support for House Bill 1310 to stabilize Medicaid reimbursement and protect access to care. Thank you.
Thank you, Jason. Thank you all for your wonderful, heartfelt testimony. Do we have any questions? Rep. Khan? Rep. Menser, Chairman Menser, do you want to go first? It's Monday morning. I'm sorry.
No problem.
I was at Pride all day
No
yesterday.
problem,
I'm
Chairman.
tired.
My question is for Mr. Quinn. Of course, when you mention Lancaster County, my ears perk up because I know there's an awful lot of facilities in the county, and I represented a lot of them. But my question is this. You mentioned a 5-star residence in Lancaster County that has cost per care of $584 and reimbursement of $316. Does that include nursing facility quality incentive payments, access to care quality paid per claim, and other payments made?
Sure. I don't know the answer to that, whether that includes those additional mechanisms, but what I can tell you, Phoebe's case study does include those.
Mm-hmm. Well, I'd be interested to know that, so if
Certainly.
you could get back to me on
Sure.
that'd be great. Thank you
Yep,
very much
you
for presenting.
Sorry. I can let you know, Chairman, the $319, that is their base Medicaid rate. That would not include their quality add-ons.
Thank you very much.
Representative Khan?
Thanks, Chair, and thanks to you all for your testimony. Appreciate it. Just 2 questions. I'm a supporter of this bill, House Bill 1310. I think it's well intended and well written, and I think it's going to help address this problem to make sure that our nursing home providers are going to be able to take care of the patients and take care of their operations. Just really 2 questions, sort of like playing devil's advocate, some of the criticism. So for the first one is, how do we make sure that, so we're increasing the funding, the base level funding, how do we make sure this gets to patient care to where it's needed and not some Prospect Medical deal where some corporations just padding their profits for their shareholders? The second, let me, I'll ask that and then I can answer the second question. Thanks.
Sure. It goes. Oops, sorry. It goes back to what Jason alluded to, the 70% accountability that was implemented by the legislature back in 2022. That requires that 70% of those costs have to go towards resident care and other resident related. So it's ensuring that it's going to the bedside, it's going to wages.
So we can feel good about this bill, that it's not just going to be spent on shareholder profits and CEO money, right? The second question I have is, again, playing devil's advocate. I heard from a stakeholder in the home care group that by increasing funding through the BAF, through this bill, we actually will upset the mix, sort of the funding mix, how things work in terms of how different entities get paid for providing care. Can you respond to that and how this actually is needed and this is not really upsetting the apple cart in terms of reimbursing care?
Yeah, I can talk about that for a moment. I just, first thing I would just say is the whole continuum of care is challenged in Pennsylvania. So obviously we're focused today on the BAF and skilled nursing facilities, but to your question on home care as well, just to be clear on home care, the average wage is $13.30 an hour for a caregiver. That is not enough for anyone to live in the Commonwealth of Pennsylvania, no matter where you are living, whatever county you are in. So we have a challenge there. And then we have a real challenge in our nursing homes. And so I think what I would say is it's on all of us to figure out how are we, I think, leading in this moment to make sure that the resources that we are putting in are getting to the fact that we need good jobs across the care continuum. I think we've put safeguards in place in nursing homes to make sure that the 70% rule is in effect. It's part of why we've built a strategic partnership with PHCA, which is to make sure that we are, we represent 117 nursing homes, and they happen to be the vast majority of them, including Phoebe, by the way, the vast majority of the homes that we represent 20% are high Medicaid homes, which happen to be the poorest population in the Commonwealth. And so we think there has to be a real sort of get our arms around, work with the most responsible operators to make sure that we are getting funding stabilized to make these good jobs. It's going to be really important. At the same time, the governor has proposed resources for participant-directed home care. We think that is one way in which the state can directly, pass money to the consumer who hires their caregiver to be able to lift wages directly. So that's one piece. But I would just say overall, we think that there's billions and billions of dollars that go in, and it's kind of on all of us to figure out how do those billions of dollars get to the caregiver and the person receiving that care, whether they're in the community or whether they're in a home. We support the fact that people should get their care in the right setting, in the setting of their choice. But I don't think it's what we can't do is kind of have the resources compete with each other. We think it's the challenge here is we've got to get to good jobs. We've got to make sure that we're delivering high quality care, and we've got to make sure people are getting the care in the right setting. So hopefully that helps.
Representative Nelson?
Thank you, Madam Chair. As Representative Coleman was saying, he's all in on the BAF. I'm not sure that I'm all in on the BAF. I have to, just full disclosure because of concerns and obligations. It definitely seems that the BAF would be able to create more reliable funding streams. With so much flux happening in D.C., and I don't know the details of what the final form regulation. Is there something already in the mix that's going to be helping facilities in this final form that we don't know what's going to be the impact of some of those changes in DC? And from my mind, we lock in a recurring amount, and then there is another change that comes, and we almost overcorrect, if that makes sense. Can you touch on that?
I think so, Representative. So to answer your question, is there going to be in that federal reconciliation bill a direct impact on nursing home Medicaid reimbursement or payments that go to nursing homes? Right now, the answer is no. And the real target was the provider assessment payment, at least originally. And the U.S. House passed its version of the bill that said we're not going to decrease the provider assessment, which is good, but we are going to freeze it in place so states can't raise it. Now, that doesn't necessarily impact us here in Pennsylvania, but it could impact states across the country. I think where we are most concerned is some of the other implementation that could take place. So you have Medicaid work requirements, you have eligibility checks, you have a Medicaid look-back period that's going to go proposed from 90 days to 30 days. These things could all force the state to have to cost shift, and states across the country to have to cost shift. And there is always that fear that to pay for this, you'll have to pull from that. And that could be nursing home reimbursement. That could be a number of things within the state budget. But our message has been consistent since the start of this budget cycle that we can't wait to see what Washington, D.C. does. We can't be beholden to what Washington, D.C. might do in this bill or beyond. We've got to make our priorities now. We've got to set our priorities now. And that's why we're asking you to do this in this year's budget.
And just a basic question in the BAF. We were talking about this last week. One of our providers, they're losing, I think it was $154 a day, between their facility, and they have 1,000 clients. So it really does create a strain. But where does the BAF go? Which is, so if there's $100 million in funding, we're sending out $84 million. Where's the other $16 million go?
Yeah, it's never allocated to begin with. So it's not sitting in some state account accruing interest. It's never allocated. But again, I think you've heard loud and clear, that's based on what providers should be reimbursed, based on audited cost reports that they submit to the Department of Human Services. So I don't want to say that funding is rightfully to the provider and to the caregiver and to the worker, but it certainly should be.
Mm-hmm. And last question, Madam Chair, if I can. So we're struggling. I had previous testifier, we brought up this over $900 million going to CHC. It's been explained to me there's not a guarantee that that $900 million is really going to positively impact wages or facility costs. So the difference between the BAF and the 70% ratio, even though it's a smaller amount, if she was around 350 million, I think was said in the, so my concern or my priority is dollars making it to facilities to keep their doors open and the workers so that we can better address all these unused licensed beds that we can't. 900 million going into CHC versus 350 million going towards the BAF. Can you touch on the impact to the facilities and the workers between those two ratios? Because I don't know that the 900 million in CHC is really moving the needle in those areas.
Yeah, I think I can. So again, just to be clear, as the chairwoman noted at the beginning of the hearing, so with this bill, if the bill is run, there would be an amendment that would pause rebasing for nursing facility rates for the next 2 years. So the cost wouldn't be 350 million state share, it would be about 139 million state share. Now that would get a federal match, and it would increase that ultimate reimbursement this year to about 320 million between the state share and the federal match. What I can tell you is that here's how the system works now. So we fight for a Medicaid reimbursement increase every June, and then maybe it's allocated. And you heard the department say 3 years ago it was 17.5%, and then it was 1.88%, and last year it was 7.04%. But in Pennsylvania, those new rates are not paid until July. So what you don't hear is the volatility that takes place those next 6 months when the floor of the BAF falls out. And providers have no idea what to expect in terms of what they're going to get paid. So again, they can submit their cost reports and they know what that reimbursement should be based on acuity or sickness levels of the residents and their staffing costs. But then the BAF kicks in and they have no idea what to expect for that next quarter. So when we're talking about the 70% accountability, or we're talking about sustaining wages for staff, or when we're talking about resident care, providers cannot predict, especially over those first 6 months until rates start to get paid, what they're going to be reimbursed for those months. So the system as constructed today, whether it's the 350 million or the 900 million that's the cost to carry for CHC, the system today does not work. The system is broken, and that's exactly what we're fighting for, that predictability and sustainability. I hope that answers your question.
Yeah, it was helpful. It's a confusing issue, and I appreciate the hearing, Madam Chair. Thank you.
Thank you. Representative Kozarowski?
Thank you, Madam Chair, and thank you, everybody, for being here today. It is a confusing issue, no doubt. So your information this morning for this hearing was very helpful. And I think Chuck said it best, we're just asking for a reasonable floor. I think that's something that in this unpredictable environment that we are navigating, I think the resources to the bedside, I think we should just put more Tinas to the bedside. That should be your new slogan. And thank you for what you've done in your career over the last 40 years. Thank you very much for the work that you've done. For the clients that you take care of, because it does make them safe and happier, and the sustainability of our program. I hate to hear these places closing. It's really catastrophic to what's happening in our Commonwealth as we have the, I don't know if anybody said it, I saw it in one of the silver tsunami that is coming our way here. My question really had to do with, and it was touched upon, but I just need a little further explanation. The acuity, how often is as providers, how often are you reassessed for the acuity of your patient care? How does that work, and what does that have to do with the reimbursement?
Thank you. So at each quarter, the facility's case mix is updated. So that can fluctuate throughout the year. But as we've indicated, that's something they're submitting, and they can kind of predict with some level of certainty what their rate should be, depending on that change in their residents' needs. But the BAF is, again, the unknown factor each quarter. You don't know what percentage will be deducted from that.
With this House bill, and I see I'm not on it, so I have to sponsor this. I don't know if you are either, Tarek. I don't know if you're on this bill. You have to,
I'm like fourth on
Are you
it.
on it? Okay.
Yeah.
I have to get on it. Would this be helpful for that situation?
Yes.
Okay.
Yes,
Thank you.
I know. You can speak about variability in a couple of ways. You could look at variability in rates across providers or across your own case mix fluctuating throughout the year. But then there's also the variability that comes specifically because of the BAF, and that's what we're trying to address. we have providers who, because of that quarterly fluctuation, they can't accurately budget their own spending for the year out, and that can impact things like long-term financing or raising wages for staff. They can't commit to things like that because they don't know how much that BAF might drop their rates the next quarter.
And then you're not able to recruit and retain staff in that way, which is the whole,
got
I'm
it.
looking at Matt, because that's our next issue is the workforce, so thank you.
Yes.
And Representative, if I can just add, I think it's important to note, because we haven't touched on it yet, Pennsylvania is about to transition to a new reimbursement system, the patient-driven payment model, or PDPM. And as we've seen in states across the country, that will result in higher acuity scores. The Department of Human Services has already modeled July 2024 and October 2024 under the current system versus PDPM, and we can expect for acuity to be higher, those scores to be higher, which means the BAF will only get more volatile if we don't do something to stop it.
Thank you, and thank you for answering my question before I even answered it. I knew, you know. So thank you, everyone, for testifying. And I have one quick question out the door. Tina, you spoke to 40 years of service to seniors and that you do it because you love it. And you talk about that the demand on care is taking time away from the bedside. And, you know, I would come and visit my mom and her nails would be done, right? And she had dementia, so she said she went to the salon, but she didn't. And, or, you know, somebody would be singing next to her bedside. I would, you know, come and there would be care. So my question is really for Jason. Jason, you talk about the things you've had to do to become viable, right? You had to sell a facility. You have to reduce the beds. What does this unpredictability do to the quality of, the quality of life? Not the quality of care, because we seem to be talking about the quality of care, right? Making sure people get their medications on time, making sure they're bathed twice a week, right? Making sure someone answers when they press the button. But what does all of that do to the quality of life in a facility when you're just trying to get, you know, your beds filled and the basic needs of your residents taken care of?
Yeah, I mean, so I'm happy to say Phoebe's remain consistent in the quality of care. We've had to make the difficult decision to reduce bed size or to sell, you know, a community. If we think about Phoebe as an organization, you know, we're just trying, going back to Representative Khan's statement earlier about accountability, we're just trying to break even. So last year alone, we gave across the organization $17.2 million away in benevolent care. That's not sustainable for an organization our size. So we need to make tough decisions, and we can't, we're not going to sacrifice Phoebe's quality of care, who we are as an organization. We've been around since 1903. But it's a real fact that we may need to reduce bedsides and shut off Medicaid. And that's a challenge that Phoebe doesn't want to do, but we can't afford to continue to give away $17.2 million in charity care every year. $8 million, maybe, but not 17.2.
Thank you very much. And one other quick question. Have you found the quality incentives to be sufficient pieces of your rates?
For us, no. We haven't. So, I mean, we could dig deeper into those numbers, but I know overall, when you're looking at $17.2 million, that does not help as much.
Okay. Well, we have no further questions. I would like to thank everyone for their time to continue the conversation on this incredibly difficult and important topic. Thank you, and we are adjourned.